All right. So, where was I? So yeah, I will be sharing a little bit about my favorite book today, which is the AMC Handbook. I did not really use the AMC Handbook when I did my first attempt, but second attempt I did use it, and it was marvelous. It was great, and I enjoyed the book a lot, which is why I would really want to share that with you guys today. And yes, even though many people say that the AMC Handbook was released years ago, love, why are we talking about the AMC Handbook? It's like 20 years ago. But the thing is this. Yes, but the concepts are still the same. Your concepts are still there. The only thing which is going to be a bit different is your guidelines when it comes to management. Because guidelines are changing, management is improving. There's more research happening around the world, which is why that's going to improve a little bit. So which is why when you do the handbook, you need to tally it accordingly to the guidelines for each and every case. So you know what is the current situation of it. But medicine doesn't really change overall. Appendicitis hundred of years ago is still appendicitis today. You still need your McBurney's point. You still get your Roswick sign. So it is not like the brand new things that it's happening in medicine. It's the same old medicine that we have. Just the management is changing a little bit. So there's a key thing that I want to mention about the handbook for people who come against me telling me that handbook is old love. This topic is not relevant. All right. So when we run through the handbook, we will be picking out key points, critical errors, and checking the guidelines together. So today I'm going to try my best to explain the rules of the AMC Game Fest, and then we'll dive a few questions in the AMC handbook, and then we'll take it from there. And we have another session in a few weeks' time for more handbook cases that we can practice together. So today's session will be more beneficial for those who have exams from end July onwards. The reason why I say end July onwards is because if you do this today with me and you see the rules, you might start panicking if what you know is a little bit different. So please do not panic if yours is a little bit different. Text me, come find me. We will try to edit what we have and work step by step in the short runway that we have. And if you're a July candidate, do text me as well. I will be sending links towards the end of the session. Uh, I have separate groups for you and separate sessions for you. So we would be tackling these individual problems differently together. Because I know that we are in a crunch time for July candidates. August, September people, you have time. So before we go on, I'm going to explain if you're a July candidate, how to handle the session today. If you're August, Sept, and what if you haven't booked your exam? Because I know that we have different sets of people coming for these sessions. So if you're a July candidate, your structure should be strong by now. We are not going to work so much on structure. History taking skills should be up to standard. So all you have to do today is, as you are practicing or as you are listening to me, it should be, yeah, I know that, love. I know this. I know this. That should be the concept. And it's about the little things that you need to add and perfect your presentation and your consultation. Look at key points, look at critical errors. That's all you need if you're a July candidate and you still haven't done that. Because the key points and the critical errors, even though now in the AMC marking, they say that there's no more critical errors, if you look at the printout, you still have things where you need to mention in the case. And that essentially is what the critical errors are and key points are in the handbook compared to the marking version that you have now. And if you're an August and September candidate, good, you guys have a lot of time. Not say a lot of time, but you have a decent amount of time. So I hope you have not neglected the handbook if you're an August, September candidate. So make sure you take the history with your role play partners. And when you are taking the history in your handbook, ensure that you're able to get as much of the story and your history questions are targeted to get the correct answers from the patient or from your role player, whoever that is. And the reason why handbook is a very good tool to use is because it has the candidate stem, which is very similar to what you're going to get in the exam. It also has the exact way the role player should perform and the role player should answer. So now when you look at recalls and when you look at organizations and providers who give you questions to practice for your exam, you don't really know how the role player will think, or you don't know how the AMC wants the role player to think. You're only basing it on the little information that you have in the little stem or the little information the candidate has given to you. So that's all you know. That's why handbook gives you more information to use. All right. So spend time learning a little bit more if you're an August, September candidate. You have time. And for the best group of people, or group number 3, people who have not booked your exam, very good. I'm glad that you guys are here because this is the start. Handbook is a very great opportunity and tool, and you have an edge among all of us in this room. You have the highest edge to nail this exam. So please attempt by doing role plays early if you're a haven't booked exam candidate. And try to, I know you're worried about how much you know, but you know a lot because you've sat for the AMC one. You've been practicing doctors, you've done medical school, so you know a lot. It just has to come out in the right way, which is the struggle that many of us face. So practice the cases first with your role play partners, and then start reverse engineering and see what did I miss? How can I improve? What could have gone better? And then start writing notes. So if you have a lot of time now, start writing key points and notes. The reason why is because we tend to panic when we are closer towards the exam. And now you have to prepare what you're going to do 1 to 2 weeks before the exam. So prepare the little cheat sheets that you have so that you won't panic before the exam. All right. And I will be doing another session to explain a little bit more on introduction to AMC2, how the exam is, the different tasks in the exam, and all of that when we are closer to once the exam release date has been out. I will be running those sessions. So keep an eye on the group chat. So I'll be running those concepts questions at the end of it. So now we have quite a number of people in. So let's proper start. All right. So if you have been following me for the longest time since the day I opened the chat, you know that I emphasize on history a lot because if you look at Sir William Osler's quote, right, if you listen to the patient, he's always telling you the diagnosis. So I've emphasized on how important history taking is and why we need to be flexible when we are taking the history. And I've done role plays with many candidates, and it's very evident if the candidate has memorized the recall versus the candidates who haven't or do not know what is going on. For some reason, the candidates who do not know the recall tend to do a little bit better because the candidates who know the recall are forcing me, the patient, to go in their direction of the answer, which should not be the case because you should be taking the history entirely. And if you get a positive point in the history, please dive into it. There are many people who don't dive into it because one, it wasn't in the recall. So you're like, I wasn't in the recall, so it's not important. Or whoever you took the courses or training or practice from didn't emphasize, okay, on that thing, on that particular point. So you're like, it's not important. I'm not going to tackle this. So it's important that you emphasize and work on every key point, every positive point that you get. And please remember, when you look at the recalls, right, this is a story you are getting from one candidate out of the 40 candidates that sat for the exam on that day. And you are getting the perspective of that one person and how much they have practiced and the amount of history that one candidate was able to elicit from the exam. So you only know as much as that particular candidate knows. But that doesn't equal to knowing the entire story in the AMC. I would like to bring this up by a little example. So for example, you get a case on history of presenting complaint on rectal bleeding. All right. I think most of you would have seen the history of presenting complaint rectal bleeding case where it's a hemorrhoids. So it just writes rectal bleeding equals to hemorrhoids case. So that's the only thing you identify when you read the recall. So fine, you do the history of presenting complaint, you do your CCVOB. Now, I use a lot of short forms here and there. If you are new, please just put in the chat or someone please help the new candidates clarify this short forms that I'm using. So CCVOB is usually how we use to describe discharge, color, content, volume, odor, and blood. All right. So as we are doing this, you do CCVOB and you're like, this person says he has a lump. So because he has a lump, this equals to hemorrhoids. That's it. You stop the story there. But if you actually realize the story doesn't stop there, because if you start thinking back, why did this patient have a hemorrhoids? Because you didn't identify that because the recall didn't say so. But that should be your next question as a good clinician. Why did he have hemorrhoids? Is it an increased venous pressure? Is there something pressing against the venous wall that now there's a backflow and that's causing that venous plexus? Or is it an increased abdominal pressure that is happening? Is it constipation? Is it his occupation? Is it his diet? All these questions should be shooting in your mind when you are now wondering why this person is having hemorrhoids. And then you further ask the story, you realize that it's because this patient has constipation. And then you think the story stops there, right? But in the recall, yes, the story stops there. But if you do this case in the AMC too, you will realize the story doesn't stop there because you ask him further, he tells you, you get to his past medical history. And he tells you, yes, doctor, I was taking this pain medication, codeine. Oh, why were you taking this? Oh, doctor, because I was having low back pain. And then you realize, this is your light bulb moment. You're like, this person is having hemorrhoids because of the constipation, because of the codeine he was taking due to the back pain. And this one question changes your management because now in your management, you need to stop that codeine. You need to change that pain medication that he's getting. And this is how asking a good history will change your management. And I can confidently tell you that this is the story of the exam because I got this case in my first attempt, and I can tell you that I did get a 7 on this station, so I know this is the story. But I don't know if the story goes beyond this. Like, is there more story or another layer beyond the back pain? So if any of you get this case again, please remember to ask a good story and move beyond the layers and try to see if there was more story. So, as I always tell you, history gives you 90% of the answer. What you are doing is just confirming your answer using the investigations and physical examination and rule out other red flags that you have. All right? So, with that said, as I told you guys that the AMC is a clinical exam, it's a game that we are playing. So, we need to know the rules, right, to win this game. So, this is a couple of rules that I'm going to run through with you. This is from the tips from examiner in the AMC website. There is a document that they have. I have sent it in the group before. I will send it again. So let's run through this a little bit. I'm more keen to tell you about what things to avoid than what to do well, because I'm sure you guys will be doing this greatly. So please take a little bit of a read and then I'll run through it with you guys. While I open the chat box to read, you guys can read the... Oh, thank you for doing up CCBOB, everybody. Thanks for helping each other. So let's now dive into the different statements. If you look here, you see that use this point here, use the information to provide in your reading time and the patient's initial statement and observe behavior to focus your questions. Why is this important? I want to zoom in on the term patient's initial statement. Why? Every case, if you even look at the handbook, majority of your cases have an opening statement. And this opening statement directs your entire consult. You will be able to identify ICE, which is ideas, concerns, and expectations of your patient from that one opening statement. So how can I help you? So that means try not to start with, I see from the stem that you have rectal bleeding. Can you tell me when did it start? That's not going to work, because now you have narrowed your entire consultation to the rectal bleeding. But maybe if you had asked with, hi, how can I help you today? And the patient goes, oh, doctor, I've been having this rectal bleeding for the past 3 months. It's so painful. He wouldn't have given you the term pain if you went for a direct question. So you need to get that opening statement out of the candidate to know that, oh, pain. Now you start thinking this might be an anal fissure because rectal bleeding pain, that's a bit more of a common presentation compared to maybe a hemorrhoids or compared to a cancer. So that's how your thinking process should be. And the opening statement will start narrowing down things for you. So even when you're doing, for example, your seizure cases or your syncope cases, you need to identify, is it a loss of consciousness? Or is it a jerky movement kind of story? Which direction is my consult going? So get the opening statement out to know the direction of your consult and then clarify the opening statement once you have done that. And a good way to always start would be, I'm going to give some examples along the way. How can I help you? That's a very simple one to use. What brings you in here today? So what brings you in here today? That's another one. The other one is, may I know what's bothering you today? So just memorize one, apply in all your stations, because your patient and your examiner is different in every station. They're not going to know that you're using the same technique in the different stations. So memorize one, go for it in every station. I used how can I help you? I thought that was a bit easy and smooth for me. It was a bit faster for me to remember as well. And the next line I want to show you into is probe for more detail as appropriate, which means if you get a positive, focus on the positive, ask a little bit more questions when you get that. Now, this slide is more important than the previous one because I'm sure we're doing the previous ones really well. So things to avoid. Now, things to avoid. Have a little read and then I will run you through it. So when you are doing your stations, it is very important that you read the stem very, very carefully. It's because some stems are long, some stems are short, which is why the handbook comes in very handy, because they do have short stems and they do have long stems, and you can alter accordingly and see how fast you read or how quickly you can pick out the key informations in the short and long stems. And now we move on a little bit. We see take a cursory history, this line here, take a cursory history and jumping to a conclusion about the diagnosis or next step. So what does cursory mean at this point in time? It means a quick and superficial history. So these are for people who already know recalls and like, I know this recall, this is the answer. I'm only going to ask questions to confirm my answer. That's it, I'm done. And I'm moving on to the next station. So that should not be the case. You should be still taking a good history, confirming your diagnosis, ruling out your differentials, ruling out your red flags, and then moving on to asking your other questions, like your SADMA and stuff towards the end of it. And one thing to remember is that phrasing of your questions matters a lot. That not only shows your communication skills, it also shows that you know how to direct the consult and you know what kind of questions to ask in the middle of your consult. So let's take a look at this line. Using double-barreled questions, seeking a closed yes or no. So now, do you have vomiting or diarrhea? Well, me, when I'm doing the exam with you guys, or when I'm doing mock exams or role play, I know why you're asking this question. You want to rule out gastroenteritis. You want to rule out your GI symptoms very quickly. You're doing a GI systemic review. And it will be okay if this was a negative. But now the problem will come if vomiting and diarrhea, or one of it becomes a positive, or there's two things, and now the patient goes, yes, doctor, I have been having vomiting. And let's say you do your CCVOB for your vomiting, and you do the duration, how long, the pattern, and you forgot you asked about diarrhea, but this patient also had diarrhea. This is going to be a problem because you missed out one entire symptom. You are going to get confused. The patient is going to get confused. And if the patient says yes, my question to you is this: did the patient say yes to vomiting, or did the patient say yes to diarrhea? Which one did the patient say yes to? But questions that you can use two different things would be, is your periods regular or irregular? Very straightforward. It can only be irregular or regular. I don't know how someone is going to have both regular, irregular periods. It's a bit funny. So just think about these questions. It might not seem like a big deal when you're role playing, but however, when you start getting answers and you don't get complete answers from the history, you will realize that it's a little bit of a hurdle if this problem is not solved earlier. So if you are August, September candidate or candidates who haven't booked your dates, start focusing on how you ask those little questions because they make a lot of difference. And because you are role playing with another doctor, we know the answers. Like when you ask me a question, I'm like, yeah, I know what my friend is asking. I'm going to give my friend the answer. Your friend doesn't focus so much on the English or the phrasing, but you must understand, these role players are Australians. They're really good with English, way better than all of us in English. And they really hear your question and they answer the question accordingly. So just be mindful about that. And that's a bit pros and cons when we practice with medical friends because we know what you want and we give you the answers. Before you even ask the question, I already know the reply and I'm like, yeah, yes. So just remember that a little bit. And when they tell you taking a scattergun approach or random approach, now scattergun just means that you have to be structured when you are asking your history question. Reason because the markers have a marking scheme. Towards the end of today, I will send you a sample of the marking scheme that the AMC has released. It is super structured. And the only way to win this and to get across the bridge is for us to be as close as possible to that marking structure so that we get more ticks and that increases our chances of passing the exam. Now, when we talk a little bit about question types, now this screenshot is from the handbook. I'll give you a bit to read it and then I will start breaking it down for you a little bit. So in summary of this, for those of you who already read it, in summary of it, this is just telling us that we need to use more open-ended questions to be able to get a story. However, it doesn't mean that close-ended or directive questions are wrong. Closed-ended and directive questions can be a little bit more common when you're moving down towards the end of your consult because you're going to start wrapping up towards the end of 8 minutes. You're going to start confirming your diagnosis. So there's no time to get the whole long story these Australian patients are going to tell you. It's just about identifying the key points, confirming them, and nailing your diagnosis. So start with open-ended and then move down slowly towards a directive and closed-ended. So if you're asking me, what love do you mean if you tell me open-ended, direct, closed? I don't understand. Now, this is an example from the handbook. So open-ended questions is, tell me more about the pain. So you're leaving it open. The candidate can say anything and everything about the pain. But now direct will be your Socrates. So you do open-ended first, you do Socrates or Sikora, whichever you use, no problem. You do that. So where is the pain? Is when did it start? And all these questions you do. Now, closed question will be more or less like a yes or no. Have you had this pain before? Yes or no. That's the only way you can do that. Now, the questions that we should avoid are your leading questions. Leading questions will get your score down very low. They are not highly recommended at all. So if you're doing a consult, 60 to 70% of the time, you are between open-ended and direct and closed. You don't really have any leading questions that you should be doing. But I do realize many doctors that I work with do leading questions. Maybe because back in our culture or maybe back home, it's faster. It's faster to say, no headache, right? No pain, right? No vomiting, because we just want to confirm it. Now, this shows two things. One, you know what's going on, so you already know what is a no. Or two, it just shows that your practice of how you've been asking questions hasn't been really good and you're just narrowing it down to say no, no, no. So try asking, change your no headache to any headache. So change that word to any, and that will really help you to have an increased score in your approach and communication. And that will change your tone and mood as well. Because no now gives it a very authoritative look to it. Like, I'm telling you, you don't have a pain. No, you answer me. It's very authoritative. And as doctors and in this AMC consult, that is not something that we are trying to achieve. We're still trying to create that nice, fun, cool rapport with the patient throughout the entire consult. Now, this is something that you can see in, this one was in the Tips of Examiner AMC website page. So have a little read, and then I will narrow it down a little bit more for you. So this is all about diagnostic formulation, predominant assessment area. If you look at it, look at the word diagnosis and most likely diagnosis. Many of us tend to get confused. Oh, the one comment that I've been hearing from the candidates who have been sitting for the exam, love, I know what is going on. I know the concept, but I don't know what the question wants from me. I don't understand the task. I don't know if I actually address the task. That is the struggle that we are all now facing. So towards the end of today, I will be showing a couple of handbook cases. We will look at every task and try to see what they're trying to get from us. So remember, diagnosis and diagnosis is only asking you for one diagnosis. But if they put an ES, that means there is a couple of few of diagnoses that you have to mention. And if you look beside the yellow highlight, they have give a prioritized selection. What does prioritized selection mean? You have to give from most probable to the least. If you are confused, go back to the history of presenting complaint. Look at the presenting complaint, give your differentials based on that. I know in the middle of the history, you would have gotten a lot of random symptoms, and these random symptoms will tend to confuse you, and you start now giving differentials based on the random symptoms, but forget that, hey, this patient actually came for this problem. So today I did a case with a candidate where we did leg pain, leg intermittent claudication, leg pain. The patient came with a right calf pain. And now when we went to the differentials, now we already established this intermittent claudication. We got the whole 6 Ps. We ruled out critical limb ischemia, and we got to the end where we asked for differentials. And now we were stuck. We were wondering, now this is going in a vascular case. Shouldn't all my differentials be vascular? Why am I giving simple differentials like osteoarthritis or maybe plantar fasciitis? But if you think about it, go back to presenting complaint, right leg pain, which means osteoarthritis, neurogenic claudication. They are all still correct differentials, but now your story just helps you adjust them, which is why if you're a candidate who just throws your mnemonic and throws your differentials in a particular differential task, and if the predominant assessment area is your differential diagnosis, it is going to be a bit difficult to pass that station. All right, so just remember, keep that in your mind. The other thing that I wanted to mention as well. So for example, I have done cases with candidates where there'll be no fever, there'll be no loss of weight, no lumps and bumps in your entire history taking, negative for cancer. But your first differential diagnosis is cancer. Doesn't make sense. So look at the age range. For a 25-year-old patient with abdo pain with no red flags of cancer, is your first differential going to be cancer? No. Yes, it is a red flag. I understand 100%. It's a red flag. It needs to be in your differential, but not your first differential. So think about it relevance to the age. Again, another case that was common as well, where I saw simple problems was the secondary amenorrhea case. I'm sure most of you are familiar. You have the the one with the eating disorder, so she has secondary amenorrhea. The other one is the athletic amenorrhea, secondary amenorrhea. Two of them appearing in the AMC, a little bit more common this year. Some of the candidates give me premature ovarian insufficiency as your first differential. Again, does it really make sense? Premature ovarian insufficiency is something we see towards the later age. And this girl is a 19-year-old female who has come with 18 months of not having her periods. Again, you need to restructure your differentials. So it's not about just throwing a big range of differentials. It's about giving a prioritized selection of your differentials. So try working on that. Okay. Now, when we move to avoid premature closure, this one, the minute you do one case with me, I will know if you know the recalls or not, because you just push me to give you the answers that you want according to the recall. So please, it's a thing that they have mentioned in the rules that they have given to us. Avoid the premature closure. Avoid any kind of assumption. Till you ask, you don't know the answer. So no assumptions made in the exam. The rest of it you guys can read through. They're just simple things. I just wanted to tap on avoid using, I don't know if you guys can see it, but avoid using words like nasty. This is a nasty growth. Straight up forward, this is cancer. You have cancer. Of course, do a little bit of breaking bad news. Use your skills a little bit, but don't have to hide the word and say, oh, this is a bad lump. No, go straight, because they have mentioned to us that they don't want that from us. Sorry, this is the next page. Things to avoid. I said it a bit earlier. But yes, as I was mentioning, giving a long list of textbook differentials doesn't equal to being a very fantastic clinician. And the one more thing you need to realize when you are mentioning your differentials, mutually exclusive. So if you're going to say upper respiratory airway signs and lower respiratory airway problems, that is very different from saying you have tonsillitis versus you have pneumonia or bronchiectasis or asthma or COPD. Give the diagnosis, give your ICD diagnosis. Do not go for symptoms or do not cluster them really big. That will only score you down. So our role here is to get as many scores as possible. So if you do happen to do any one-on-one sessions with me, we will first do a couple of cases. We'll try to identify where your strengths and weaknesses are. Accordingly, the next time if you do a session with me, the questions will be targeted at where exactly your weaker points are and where your weak stations are. All right. Now, I know it's a lot to take in. Don't worry. I'm not going to say I'm going to give you reading materials. I'm going to say that I'll be giving you the slides at the end of this in a video recording. But I know it can be overwhelming, especially if your exam is in July. So the best advice is take it slow a little bit, do baby steps, and work on one issue at a time. So if your goal today, let's say, I just want to work on perfecting my differential diagnosis today. So do cases which are a little bit more relevant to differential diagnosis. Spend time asking the DDX in the history, and then spend time ranking the differentials in your DDX task. That is the one thing that you can do. And one you can remember is that just because you see particular stems or questions in the handbook or in the providers who are provided to you, it doesn't mean that you have to do the exact same task that is there or what is in the recall. You can adjust the task according to your strength and weaknesses. So if you think that, hey, I'm quite good in maybe management, it's not really a problem for me. Tell your partner, I want to spend time doing differentials. So can we change the management task to differentials with reasons? Let me spend time doing that. So this will help you. So one case, but adjust the task, because you must understand the task is ever changing in the AMC too. You need to use every STEM to your advantage and edit accordingly. And if you want to work on every problem at one time, it is going to be very difficult. You will feel very stressed. I've been there. I've gotten stressed before. It doesn't go down well. I remember I read this document that I'm sharing with you guys. I remember reading it during my first attempt, 1 week or 2 weeks before my exam. I panicked big time. I was like, oh my God, I do ask a lot of no questions. Oh my God, I do this. Oh my God, I do that. And then when I did practice with my role play partner, I could never finish on time after that, because every question I was thinking, how should I phrase this? Okay, let me change it. So it took a lot of time. So work on one thing at a time. Don't fly and try to do a lot of things. We are humans at the end of the day, step by step. Now, with that said, I'm going to move on a little bit to choice of investigations. Give you a little bit time to read, and then I will zoom in into the yellow portions that I have. The AMC is quite particular about the choice of investigations. It was not something I realized until I used to do everything under the sun. I used to memorize LFT, TFT, RFT, everything. I just warmed it up, CBC and everything. But then I failed my exam the first time. And then I got approach to patient was good. My choice of investigation was low every time. And that's the reason why I couldn't clear my first exam. I was wondering, but I tell everything that they need. Why am I failing choice of investigation? That's when I read the handbook after that, I was like, now I know why I failed it, because I'm asking everything unnecessary. So if you look at this, when you want to decide on an investigation to do, the first question you ask yourself is this: will this investigation change my management? If yes, do it. If no, forget it. You don't really have to do it. And the other thing is this: I'm doing the investigation to confirm my diagnosis. And for example, if you're doing confirmatory diagnosis, if you have scarlet fever, pertussis cases, yes, you are going to 100% do a throat swab, because you need to confirm the diagnosis and give your medications or management accordingly to that. But now let's think about investigations to do to rule out red flags. In a case of GERD, for example, a GERD case, if your history of presenting complaint is chest pain, because with your history, you know that it's a GERD. Oh, it's a GERD, lab. It's not an MI, I'm so sure. No, there are red flags where an ECG will be warranted. So which means to rule out your red flags, you need to do your ECG in your chest pain cases. So questions to ask, again, let me repeat. Will this investigation change my management? Is this confirming my diagnosis? Am I ruling out the really big guys? The big red flags, the red guys. Am I ruling them out? But of course, with that said, if you have a scarlet fever, let's say in a fever and rash cluster, you get scarlet fever. You already know this patient has sandpaper rash, had sore throat, runny nose, typical presentation of scarlet fever. You are not going to do a lumbar puncture because you think that, oh, rash and fever, that must be meningitis. I'm going to do a lumbar puncture. No, if you have ruled out neck stiffness in your history, you have ruled out blanchable versus non-blanchable rash, you have ruled out fever, all the other things that could be possible. In your PFI as well, you know that there's no neck stiffness. Clinically, you have diagnosed this is not meningitis. So why do a lumbar puncture? All right. That is something to remember. And there's one thing that I always tell you guys. For example, there are times we make mistakes when we are doing investigations. We end up saying CBC, LFT, TFT, RFT. You open everything on top of the sun, right under the sun. The way to save yourself is this, because here we are here to teach you tips and strategies on how to save yourself if you mess up. Because the truth is this: we are going to mess up. I have made mistakes during the exam, but it's all about how you bounce back that second and how you save yourself. So if you make a mistake and say everything under the sun, just say this: well, as of now, we will not be doing these investigations. I'm just going to do the confirmatory investigations. If we decide to give you any medications, then I will run these blood tests. So you save yourself by saying that if I want to give you medications, I will do this blood test to know your baseline bloods. So that's one way to save yourself. Second way to save yourself is, for now, we don't need them. I've mentioned a couple of few, but they're not confirmatory, and we won't need them. But we might need them for any kind of screening that we can consider down the road. But let's focus on this problem first. Let's example abdominal pain. So let's focus on the abdominal pain first, and then we can think about screening later on. So save yourself by using those little tricks, because we are going to. I made a big blunder. I remember in one of my cases. I still passed that case, but I saved myself somehow. I can't remember how I saved myself, but it was quite funny. And I came out, I was like, phew, I hope I didn't mess it up too big. So keep these tricks in your bags. They are very, very important. Over the time with more sessions with me, you will be finding out more tricks and tips that you can use to save yourself during the exams. And that's the only way you're going to be able to pass if we mess up or clean up the mess a little bit more. Now, this screenshot is from the handbook. The reason why I put it here is to remind ourselves that when we talk about management, or if you have a task of management, investigation is inside the task of management. Many of us just go for pharmacological, non-pharmacological, short-term, long-term as a management. But no, investigations are involved. every time, every different types that I mentioned, your pharmacological, non-pharmacological, all of them exist as well. Your red flags, your warning signs, your reassurances, they are all part of your management. So let's not try to forget that as we practice. And if you think you're forgetting, now just have a little cheat sheet or box in front of you, put it at the side, and every time when you practice, refer, at least the first few times, refer. There's no harm in referring in the first few practices when you're early on practicing AMC questions. But of course, towards the end, which means if you have 1 month left, try not to refer as much. Try to go with your own flow. Get the brain to bring out the information. The one thing that I always tell all the candidates who work with me is this: our brain remembers the last time we tried to remember something. Now, that is a scientific fact. If you didn't try to remember it, your brain is not going to remember it. And the harder it takes for you to remember, or the struggle of you trying, for example, you see something, you chat GPT it, the answer comes to you very swiftly. I'm not against ChatGPT, but I'm just mentioning that. You do it really quickly. Your brain won't remember you trying hard to get the answer. So your brain won't remember the answer as well. However, if now you think of this question, I don't know the answer, then you move on to maybe open your textbook or you open your notes or you go and figure out where is this in the notes and you read it. You refer to Telly O'Connor and the handbook or you open the guidelines. Your brain will remember the process. And during your exam, even if you forget the answer, your brain will remember the process. The answer will come to you. This is the reason why the process is so important. And training your brain to be under pressure and to still be able to bring out the information is what we need to work on when we are towards the last 1 month or 2 weeks before the exam. All right, now this is a little bit more of information on management. So with regards to management, these are things that you guys can read, but I'm just going to tap on the parts that I've highlighted in yellow. Please be aware of how to do breaking bad news stations. They are coming up a little bit more commonly. The more common ones are your squamous cell carcinoma, melanoma, thyroid, basal cell carcinoma, prostate CA. On the other side, you also have incidental breast lump and you have incidental adrenal gland adenoloma, incidentaloma, the adrenal one. So there are 7 cases, 5 cancer ones. The rest are just incidental findings. So you have to figure out, is it a cancer or not? So remember, please take note of how to break bad news. Please take your time to break the bad news. And I have a few candidates who are really cute. They forget that they're actually breaking a bad news. And they're like, oh, you have this condition, you have cancer, for example. Oh, I forgot to ask you, do you want someone there to be with you? So please, settings, use your spikes protocol, settings all the way in front. Okay, so create the environment, ask them if they have someone there with them. Already get, again, ICE, ideas, concerns, expectations. Try to figure out how much they know and what are they expecting and tap back on how much they know and then use that as a leverage for your consult. All right. And there are many of us who love to draw and write or use medical jargons. Please, you can draw, you can have the best drawing, but one, they're not going to mark you for the drawing. All right. And 2, if you draw a beautiful diagram but still use medical jargons, we're not really solving the problem. So just a little bit remember that point. And for me, if you notice, I'm a very hand person, which is why face-to-face was very I actually enjoyed the face-to-face exam because I could really be myself. When I did the online exam, I couldn't move. My hands have to be like in front of the screen. I have to make sure that they can see that I'm not cheating or whatever. So that was a bit difficult for me in the online exam. But face-to-face, I totally enjoyed it. I could use my hands. And next, for example, if you have a knee pain, like a limping cluster, point to your knee. Ask them, is it radiating up or down? Use the environment to your advantage. Use your hands to your advantage because these are things that you have. And I have candidates who also, if you want to talk about any kind of examinations, use your hands. They're really good. And if you do more sessions with me, you will learn different techniques on how to do them. And if you've been following the group chat, you would know that I'm not a very big fan of I will give you reading materials or I will tell my supervisor or I will get my supervisor in. I'm not the biggest fan of all of these. The reason is because it is every case that you get in the AMC is designed at an RMO level, which means an RMO will be able to handle it. You do not have to go in search of a supervisor. So when we go and say, oh, I'm going to get a supervisor or I'm going to give you reading materials without explaining why you're giving reading materials, it is very obvious that we do not know what's going on. So try your best to not say that I will involve my supervisor. For those of you who are sitting for the pesky exam, right? The pesky exam is for your GP pathway. Yes, in your pesky exam, you have to say supervisor. But this is AMC2. In AMC2, you don't have to. because you should know how to handle every single case that's given to you in the exam. And some of us very happily say, I will refer you to the MDT. Everyone is going to be there for you. We will be there for you. Lovely. I enjoy that. But why are we referring to this particular person? So, for example, if you say, I'm going to get a dietitian involved so we can get you a good plan and get the BMI and cholesterol level down. So, explain clearly why you are getting these different people on board. Don't just throw everything. No, no point. And if you think about it, if we are on the patient side, and then my doctor tells me, I'm going to give you all these people to help you. I said, okay, how are they going to help me? And it feels very overwhelming as a patient, like, oh my God, there's so many, is my problem so big that I need so many people to help me? So no, make it very clear why we are having the different people to help us. So again, for CBT, very commonly that we use for psychiatry cases, the psychologist, you can say, the psychologist will be able to support you with a CBT. And this might change your thought process and perspective towards the situation. And that's what we are working towards. So be very nice and practice these sentences. The thing is this, these sentences are not going to come to you during the exam. You have to prepare these sentences before the exam. This should be ready because in the exam, you only have 8 minutes. You do not have 8 minutes to think of the right words. And you must understand, all of us are not the, I mean, for me at least, but I'm not the super best at English. I do struggle with English once in a while. So, and I don't get the words very quickly. You see me stem a little bit here and there. I'm thinking of the words. And even for today, if you're wondering how I'm flowing, it's because I do have a script right out. I do have my key points written down, which is why I'm flowing a little bit more easily than if I just randomly did it with no plan or no strategy. Which is why please plan, think early, strategize early. When you go for the exam, only time for execution. No time to think of, should I use this or should I use that? No. Take that backpack that you have, throw out what you have, and just use them. I know the first part was a bit heavy. Okay, so I know it's really long. So any questions at this point in time? I'm going to open the chat box and check if you guys have any questions. What were the counseling stations mentioned? The counseling stations, I believe I mentioned about basal cell carcinoma, squamous cell carcinoma, melanoma, thyroid, and prostate cancer for your cancer cases. And for your other lump findings ones, is your incidental loma for your breast lump and your adrenal gland. These are common cases that do come up. Now, someone asked, in terms of reading material, can I say, yes, so you can say that I will be giving you reading materials, but let me explain the situation first, or let me explain the condition. And if you're confused, you can refer to the reading materials that I'll be giving you. So don't just give reading materials and end it there, like, okay, I've done my job, I've thrown this away to this patient. History taking for 2 to 3, 4 minutes during. Well, JP, you asked this question. Actually, no, not really, because you are still asking questions in clusters, which means, let's say, okay, let's example SITS counseling, yeah? So SITS counseling is a 4-minute history, and it has a 4-minute counseling session. So you're going to do a very quick history. Now, you know that if you're going to counsel someone for SITS counseling, all you need to know is, one, this mom, is she in postpartum blues or depression? Get the red flag out of the way. Is the baby healthy now? Get that out of the way. Start thinking about risk factors that you want to rule out for SITS counseling. So, okay, is the mom a fan of immunization or not? What is their social economic status? Do they have a cot in their room, or are they going to sleep with a baby on the bed? Are they going to do breastfeeding or bottle feeding? So yes, you know the recall, but your questions are very targeted to the risk factors. So the recall only gives you 1 or 2 points which are positive in the cluster of questions, but there are still a whole lot of ton of positives or questions you can ask in that cluster, which will help you get your answer. All right. All right. If there's no other questions, let's take a 5-minute break. I believe it's 7:48 in Melbourne. So let's 7:48. Let's come back at 8:53, I guess. Make it easy. 10 minutes, guys. I'll do the math. 10 minutes. I have a timer on the screen. I think that'll be easier for all of us. As you can see, I'm not the best at math. So I got a timeout for all of us. We'll go for 10 minutes. Okay, 10 minutes. Timer ends and we come back. Meanwhile, I will be addressing the questions. So if you miss it, you can always refer to the video recording, which I'll be sending tonight. Breaking bad news counseling sessions. I heard. Oh, well, JP, you asked the question. So the patient actually only went for in that particular stem, according to the recalls that we have been seeing, that patient only went for a biopsy because they still don't know that it was a carcinoma. They went only because of the of the lesion. So only after the lesion has been excised, then it was biopsied, and then they realized, oh, it was cancer. And now you have to go for further re-excision and biopsy. So they don't know that it's cancer. So some people, yes, JP, yes, some people jump straight into going to the recall. But the truth is that if someone comes to you, you know this is going to be a cancer thing. Okay, what would you do? You would ask them whether they are fine, whether they're okay. What are they expecting out of today? How much do they know? So get the idea of how much they know from what they have done. Or why did you do the biopsy? Did you know why you did the biopsy? And the lady will be like, oh yeah, doctor, this other doctor told me it might be cancer. They had to check it. So I did the biopsy. You're like, okay, she knows that this is going somewhere in cancer direction. I can spend time breaking news, but not so emotionally. Okay, next question. Please add me in the WhatsApp group. Yes, I will. Towards the end of today, okay? If not, there'll be too many people. I'll send the link for the WhatsApp group at the end, and then we will sort it from there. What else? Well, requesting investigations, again, remember, John Murtagh goes by symptom base. So John Murtagh goes abnormal uterine bleeding, possible, and then all your investigations for abnormal uterine bleeding. But here it's not that. You have a diagnosis, so narrow down to that diagnosis, pick a few which will be important from the list that John Murtagh has mentioned. How to differentiate How to differentiate break? You're panicking on Breaking Bad News, JP. It's okay. No, you will know. Well, chlamydia infection. Well, yes, it's curable. Not a. So you won't really say the reason why. So the cancer diagnosis is a Breaking Bad News because this patient, it's cancer. It's a big diagnosis. It might spread. Not always to be aggressive, but you have aggressive cancers, and it can spread. That's why it's breaking bad news. But why is chlamydia infection a breaking bad news? It's because of it's how easily it can be spread to others and how this actually changes their life. And there are a lot of implications that can happen if not treated. So do not have to ask like so many questions and do you need water? They're not going to cry. In a chlamydia infection, they're not going to cry. And if you noticed one thing, when you have the STI case on the chlamydia infection, the patient already knows that he's susceptible to chlamydia and or not chlamydia, but an STI. The reason is because he came to the consult telling you that he already had casual encounters and he wants to check STI. So this patient is a patient with full on insight. He's coming to you knowing. So it's not really a BBN station, but just because you're telling this, just say that, do you need someone here with you? And then just move on. They won't really cry. So that will save you. Oh, welcome. If you guys have any questions, you can post in the chat box. In the meantime, let me throw up the links that I have for our WhatsApp group. For those of us who are not in our WhatsApp group, I will control C, right? Control V. Okay. This is our link to our WhatsApp group, so feel free to join them. I will accept the request tonight or after the session, guys. Okay, so JP, for this question, the DD, no problem. You're just asking questions which all of us think are important, but it just doesn't occur into our minds. And I definitely had this question when I was studying as well. So now the DD task, it depends. Mention diagnosis. Mention means just mention. Explain diagnosis. You don't have a choice, but you have to explain. So this depends entirely on the task and how it is phrased. All right. And if they don't ask you for differential diagnosis, diagnosis or differential diagnosis, don't have to give your other DDs because the question didn't ask you to do that. If you do that, the examiner will tell you stick to your task. So the examiner in the exams do ask candidates to stick to their task. I got that a multiple of times because I used to start talking about DDs. It just became a habit and they're like stick to your task. So you will be pushed back on track if you are doing that. No, Param. Follow-up clinic consults. Well, usually if it's a follow-up clinic consult, you will 100% know from the stem. You will know it because they will tell you that this patient did a blood test results from a previous time. That's why they're here to see you, or they've done investigations and they are here, or you had a previous consult with them and they came. But it's not as common. Only during investigations I've seen this come up, whether it's a CT or X-ray or blood test. Otherwise, not really present. And if you have to explain the investigations, then these things come up. So when you have such stations, it's very good to then ask the patient, I know that you came here previously. Can you tell me a little bit more about why did we do the investigations? Or remind me, can you please remind me what were the investigations for so we're on the same page or I'm on the right page? So use these words, start practicing these words early. So it will, when it goes to the exam, it's just take out from your brain and throw it. No need to think. In emergency cases, go in straight away. Ask. So when you start the exam, the examiner will tell you, "Can I have your ID?" They will check your ID and everything, and then they will ask you, "Do you have any questions before you begin?" It's standard for all the examiners to ask you that. And if you are concerned of emergency, you are concerned of hemodynamic stability, straight away tell the examiner, "Can I know the hemodynamic stability of my patient?" The examiner will give you three answers. One, carry on, no problem, carry on. Two, if that station has a PIFI task, the examiner will tell you, wait for the PIFI. Or the examiner will just give you the what do you want to know? The examiner will ask you, what do you want to know? And then you go, blood pressure, heart rate, oxygen saturation, temperature, list it out. And then the examiner will give you accordingly. And then you can figure out if your patient is hemodynamically stable or not. So just ask. Can you please post medication charting recall solved in the group? This station looks very easy. Well, it's not as easy because medication chart. I don't like medication charts because I'm always afraid that I'll miss a point or miss a page. So I'm not the biggest fan because I think it has 4 pages and you got to flip it. I didn't get any medication charts, but yes, I'll post an example of a medication chart. No problem. Let me write it down so I don't forget. And guys, I tend to lose the paper sometimes if I don't find it. So remind me that I need to send a medication chart if you're in the group. All right, we are down to our last few seconds. So I'm gonna go back to the welcome, guys. I'm gonna go back. Any other questions that I missed? Open-ended. And by the way, yeah, someone was asking about hemodynamic stability and emergency cases. On that note, I did have a case where patient had vaginal bleed. This is my real exam, by the way. I mean the face-to-face. I had a patient with vaginal bleeding case, and I was concerned of hemodynamic stability. So when I went into the exam room, I started with hemodynamic stability, and the examiner told me you will find out during the PIFI. So I was like, oh, okay, fine. So I continued with my consult normally. And when I went to the PIFI and I asked for hemodynamic stability, at the very same time I was asking for hemodynamic stability, my patient was going into cervical shock. So blood pressure was down, down, down. Her heart rate was high. And I was like, I'm going to bring her to resuscitation room and continue the consult. And she became okay. So please, it's honestly, if I hadn't thought about it, I would have panicked. But because I had a friend who went for the exam before, and my friend did warn me of such crazy stations, which is why I quickly knew the right words to use and say that we'll continue this in the resuscitation room. And then that's it. It was done. She became almost normal after that. Okay, I'll continue talking. Okay, I know a few of you guys texted me personally to handle PV station, so we'll get to that later on. Is it a good idea to start? Okay, the remaining questions I'll handle later on, okay? We'll continue back. I want to finish in about 20 minutes. All right, we're doing a case. Anybody? Just open your mic and tell me, and you can start the case. I'll give you time. Not a super hard case, but there are some tips and turns and falls. If no one's gonna do the case, then I will run through the cases. No issues. Anybody? Anybody? Okay, if there's no one, then I'm gonna run through the case. This is your good, great chance to practice. Don't be worried about all the other doctors. Let me tell you, we are all in this struggle together. Half of us do not know what on earth we are doing. Okay, go for it, essay. I didn't know what I was doing half the time. So yes, most of us don't know what we're doing until we try and we're like, okay. So essay, I'm gonna show you the case, and once you don't have to open your screen, just turn on your mic when you want to speak, all right? Okay, I'll give you 2 minutes. 2 minutes. So as Dr. SA, I don't know what your full name is, but as Dr. SA is reading for the rest of us, I'm just gonna tell you a few things, okay? Dr. SA, you keep thinking, okay? Don't get distracted by my voice. So if your exam is in July, which means it's this month, right? If it's in July, please just only spend 1 minute, 35 seconds reading, no more. Because you must understand there's no time. Your 2 minutes starts when your 8 minutes ends in the previous station. You do not have time to, you would never get your complete 2 minutes except your first station. Only your first station is a full 2 minutes. So if you are a July candidate, start reading your task in 1 minute 30 seconds or 35 seconds. August and September, you can go for 1 minute 45, but cut it down. So structure the entire consult in that 1 minute 35 seconds if you can. All right, time's up, Essay. Let's go.
Okay, hello, my name is Dr. Sarah, one of the doctors here. It's really nice to meet you. How can I help you?
Oh, doctor, my name is George.
Oh, hello, Josh. It's really nice to meet you. Can you tell me what brings you in today?
Oh, doctor, you can't even believe it. I was playing tennis yesterday and I blacked out. And my friends thought I was dead, doctor.
Oh, I'm so sorry to hear that. Can you tell me more about it?
Oh, doctor, let me tell you all about it. I was enjoying my usual Sunday morning, doctor, game of tennis. It was such a hot day. I had been serving, everything was going well. And then I blacked out. There was no warning signs. But my friends told me that before they wanted to do the CPR on me, I came up really quickly, and they couldn't tell if I was breathing or not. They couldn't even feel my pulse, doctor. I didn't want to play after that because I was also scared after what happened. And I just grazed my elbow a little bit. I didn't get any other injuries, but just my elbow.
Okay, I'm so sorry to hear that, Josh. That sounds like such a terrifying situation to be in. But can you tell me, you said that there weren't any warning signs. So can you tell me if you experienced any pain before that?
No, doctor, like no pain.
Okay. And has this kind of thing ever happened before?
No, it's the first time, which is why I'm so concerned when I came to see you. But it's like everything came back to normal. Like nothing ever happened.
Okay, okay. I understand. And so you said that you were with your friends at that time. So can you tell me if they told you like how long were you unconscious for?
It was really quick, doctors. Like before they could come towards me and do a CPR, I was fine.
Okay, great. And so you said you lost consciousness, right?
Mm-hmm.
Okay,
Yeah.
and were there any jerky movements?
No,
Okay, and any perhaps any tongue biting?
no.
Okay. And once you came back to consciousness, you felt fine. You
Yes, doctor.
mentioned that you were feeling fine, but you decided to stop playing.
Yes, doctor. I was so scared after what happened, but I was fine.
I can understand. Also, can you tell me, was it like really hot that day?
It was hot, but it's normal. Like it's always been hot every time we play tennis, so I don't think that's the problem.
Okay. And do you have any other heart conditions?
Not that I know of, doctor. I've never really checked, to be honest. But the last time around, like I did for some kind of checks, they told me that like my fats level is a bit on the higher edge of the normal. But I said that I'm a fit person, so I didn't really do any follow-ups.
Okay. And about this loss of consciousness, were you perhaps confused when you came back to consciousness?
No.
Okay, and were you experiencing any shortness of breath, any chest pains?
Not really at this point in time, doctor. I didn't feel any chest pain or shortness of breath, but I do notice that like over the months of playing and walking, I do get like shortness of breath, but I thought it's because I'm just getting old.
Okay, can you tell me more about this shortness of breath?
What do you want to know about it?
You mentioned that it only happens when you play tennis. Does it happen on other occasions as well?
No, maybe when I'm like having like really far distances that I'm walking, or maybe like when I'm playing tennis. Otherwise, I've not really noticed it. So I just thought maybe I'm getting old.
Okay, any other symptom like any cough or any
Mm,
cough along with that?
no.
Okay, and are you taking any medicine?
No, I'm quite healthy, doctor. I don't take any medications.
Okay, that's great to hear. And do you smoke,
Nah.
drink alcohol?
I mean, socially, that's about it.
Okay. Any past family history that I should be aware of?
Not really, doctor. They're all normal. Like, I mean, everyone just died of old age, if that's what you're asking.
Okay. Okay. Uh, any okay, I'd like to thank you for giving me the history. I'd like to talk to my examiner and then I'll get back to you, okay? Is
Mm-hmm.
that okay?
Yes.
Okay. The examiner, I'd like to know the physical examination findings. So can I please know the vitals of my patient?
What do you want to know?
Can I know the blood pressure, both sitting and standing?
118/88, sitting and standing. This is your
Okay.
5-minute prompt timer. Continue.
Okay. And how about the pulse?
70 beats per minute, regular.
Okay. And on inspection of the cardiovascular system, is there any visible apex beat?
Apex beat not displaced.
Okay. And on auscultation of the valves, are there any murmurs?
Ejection systolic murmur present.
Okay. And are there any carotid bruits?
Carotid bruits present over both carotid arteries.
Okay. And do we have any office tests available in ECG?
No, pending.
Okay. And are there any neurological deficits?
No, normal. ECG is normal as well.
Okay. Okay. Any blood sugar levels?
No, no,
Sorry, what did you mention about on the
normal. ECG
auscultation?
is normal. Every other examination, excultation, murmur present.
Yeah,
Ejection
auscultation.
systolic murmur present.
Okay. So, examiner, I think most likely diagnosis of my patient is aortic stenosis. The reason I'm suspecting this is because of the shortness of breath and the exertional syncope, and also
Mhm.
because of the ejection systolic murmur.
Mm-hmm.
So I'd like to talk to the patient now.
Yes, doctor.
Hello, Josh. So Thank you for giving me the history. So, for what you've told me, I think you're suffering from most likely condition called aortic stenosis. Do you know
Mm-hmm.
about it?
No.
Okay, so I'll draw a
Your
picture for
task.
your better understanding. But
Your task.
so yeah, okay, so aortic stenosis is a condition that affects your valves, or these are like doorways in your heart. And in your case, the doorway between
Stick
one
to your
of the
task.
heart cha okay,
Read that. Go back to the task. What are they asking for?
okay. So John, I'd like to do further tests for your condition. So I've already done an ECG, but I'd like to do an echo, which is kind of like an ultrasound of your heart to check whether the valves present in your heart are narrowed.
Mm-hmm.
And I'd also like to refer you to a cardiologist who will decide on your treatment
Mm-hmm.
based on the results of those echocardiogram. If it's relatively normal and
Mm-hmm.
not too bad, then the cardiologist might go for a wait and watching approach where
I
you
see.
will be regularly followed up.
Hello, hello.
And
Thanks.
if it
It's over.
okay,
Okay, well done, well done, well done. It was very good. It was, I mean, you nailed the diagnosis, but now um, I'll give you your feedback. Yeah, drop me a text. I'll give you a personalized feedback, and then we'll run through the case together, everybody, okay?
okay, great.
Now, let's break down the case together. Well, it was a decently good approach, but there could be a bit of more things that could have been a bit better here and there, all right? So, looks like a very easy stem, looks like a very short stem, but a lot of things are going on. So you got the history of presenting complaint, you have the age, which tells you, can go towards valvular disease. So your task, you have history from patient, ask the examiner the focused physical findings from this, tell the examiner the diagnosis with reasons. So read the task properly because we will be marked down if you don't address the task. And the last one was indicate to the patient, all right, the further assessment that you would do. Take a history. I think all of us know that task really well. Now look at the second task. Focused physical examination, which means zoom exactly what Dr. Is it Sarah? I think Dr. Sarah. I think Dr. Sarah did. Zoom straight into your general appearance, your vital signs, your cardiovascular, rule out neuro complications, any neurovascular deficits that could have happened from the syncope episode. Very straightforward, very good. Finish with office test. So that was perfection done with your structure of your PV. There could have been a couple more things inserted inside, but structure-wise, no comments. Now, tell the examiner your diagnosis and the reasons. The AMC doesn't always put S at the back, reasons or reasons. They don't know there's more than one reason as to why this patient is having aortic stenosis at your diagnosis or why the patient had a recent transient loss of consciousness. And if you look at the next last task, indicate. Indicate is very similar to mention, just tell only. Don't have to sit down then. If you have time, yeah, you can sit down then explain everything. But indicate means just tell and move on. So indicate the extra stuff that you want to do, the further assessment that you want to do. So now let's dive a little bit. So in this case, now the key issues. The history has to elicit your syncope, exertional dyspnea, and chest discomfort. So where will this part come? When you are telling the examiner the reasons for your aortic stenosis diagnosis causing the recent the syncope episode. So again, there are layers to this. These symptoms equals to AS, and it's the AS that caused your syncope. So syncope, exertional dyspnea, chest discomfort. So I could have done a little bit more with asking a few more questions with your CVS symptoms. Yes, you asked for pain, but you didn't specifically ask me for chest pain. You just said, do you have pain? And mom's like, well, what pain? I was like, no, I don't have pain. But then more questions, palpitations, discomfort, throw more. You only asked a couple of you, cough, shortness of breath, and the story went a little bit more. You found out that I do get a little bit shortness of breath on walking, and you focus on that. But there are more symptoms to identify. An examination, as she did, well done. She did pulse, BP, and carotid murmurs and cardiac murmurs. Now, the issue that I had here was, yes, you identified there was an ejection systolic murmur. Fantastic. You don't know where the murmur is. So how do you know it's aortic stenosis? I mean, yeah, most likely 80% of the time it's AS in these older people, but you don't know. So again, if you get a positive, even from the examiner, Ask your examiner to describe the characteristics of the murmur. What is where, the site of it? Does it radiate? Are there any kind of maneuvers that accentuates your murmurs? And then from there, and the grading of it, the grading and the character of it. So get these all out from the examiner. Then this is aortic stenosis. It could have been a mitral valve murmur too. It could have been a mitral murmur. You never know. So get that right. And then you did talk about ECG and echo, so that was wonderful. And the diagnosis, again, to always understand that there are layers to the AMC case and identify. So again, for candidates who your exams in September, or you haven't booked your exam, when you are doing handbook, start looking at the key issues and critical errors and start noting them down, because every syncope case, most likely, not it's going to be aortic stenosis, but most likely these will be the key things that you need to mention about if the case goes towards an aortic stenosis direction. So start remembering them. If your exam is in the next few weeks, July, people, open your book, just read these things. Know that if you are doing a syncope cluster, these things have to be ruled out. If you're doing any cardiovascular based case, you have to ask for your carotid and cardiac buoys, because that might be a critical error in that station. So just remember that, and link it back. Link your PV back to your physical examination stations, where you can or should be asking for carotid buoys and cardiac buoys as well when you are doing the CVSP. So that's how you make your learning just not stick to history and CVS and handbook. You change it. You push it to different cases. Take one, leverage on it, bring it somewhere else. Now, if you continue reading this part, the next one's a bit long. Yeah, it's a bit long, but I'll give you time to read and then I will summarize it and break it down for you. The yellow part's a little bit more important than the other parts. So the task specifically said take a focused physical exam. So when your focused physical exam means you just have to confirm your diagnosis, rule out your neurovascular deficits. That's all you're going to be doing. So what Dr. Sarah did was perfect. And as I mentioned, if you have done additional investigations with regards to the investigations part, I told you a few tips and tricks on how to save yourself. And this is why I tell you AMC is very bothered when we do over testing, because this is only one comment. You will see this comment appear multiple times in the AMC handbook, where a lack of understanding of the condition is exhibited if the candidate asks for a whole range of investigations. So they will fail you under choice of investigations if you did everything. Not necessary. And Dr. Sarah, you did ask about BSL. Yes, you asked BSL, but then where was the question about missed meals? So try to see if your history can first rule things out. PE and PV is only to support all the answers you already have. All right. And one thing is that, I'll reverse back a little bit. When you are explaining the investigations, or even in a normal consult, if you find yourself stammering or struggling, take a pause. Take a pause and use your hands if you need to. Take a pause, bring the ball back to your court. And let's focus on this first, and then we'll do that later. Or this is a secondary problem, we'll do that later. I'll get back to that towards the end of the consult. Well, whether you have time or not, it doesn't matter, but the examiner will know that this candidate has this point at the back of their mind, but the candidate also knows that this is not as important as of now for this consult. Therefore, the candidate is going to focus on important things and then the least important things. So show that, exhibit that in your consult. Okay, I'm going to open the chat box for a bit if you guys have any questions about. Oh, yes, you did very well. Okay, so for the murmur part, please ask for the character of the murmur, the site, the radiation, the grading. Site, radiation, grading. Means when task. Yeah, so just give a few. Give the safer ones, and then you can do the rest after. Okay, next. Oh, we already have someone, so I don't need that. We already have someone for us. Nikhil, right? So I'm going to give you your time. Again, I will be giving you 2 minutes, and then we will finish it off. This is our last case for today because I know that it's going to getting a bit late. Nikhil, you're there, right? If Nikhil, you're there, just thumbs up for me in the. Ayo, no, not a problem. Okay, no problem. Next time around, okay? No stress. I'm sure all of us are struggling and learning. Dr. Sarah, you did really well and you stressed our doctor out. No problem. Let me run through the next case for all of you guys, and then we will do it together. Okay? All right. So this is the next case. Read this case. I know it's let me just show you how I have already divided it for you guys in colors. Not a very easy case. There's a lot of things are going on. So take a look at it. This was very similar to the case that I got in the in my AMC2 face-to-face exam, so I panicked. Oh, Swana, you want to go for it? Okay. Sorry, you did it once. We'll do it again the next time round. Let's get Dr. Swana to go for this one, okay? Okay. Dr.
Yeah.
Swana, you're only going to get like 1 minute, 30 seconds.
Okay.
Okay, I'll time you 1 minute, 30 seconds. I know your exam soon. And while she's thinking for the rest of us, if you are training, if your exam's in July again, yes, you read for 1 minute, 35 seconds. But if you are practicing the consult, make it 7 minutes, 40 seconds. I usually give most of my candidates 7 minutes, 40 seconds because when you go into the exam room, the examiner is going to say hi, the examiner is going to check your ID, and then you're going to panic. So a lot of things happen. So give yourself 20 seconds buffer to sort all of these things going on and do a shorter time so that in the exam, you need to be prepared for the bad things that can happen. I know it's overthinking, but things mess up. Life happens. So give yourself 20 seconds buffer. So only do it for 7 minutes, 40 seconds. So right now, I will only give you 7 minutes, 40 seconds as well. Because yeah.
Okay. I'm sorry if the background noise is disturbing you, but
Oh, no, 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 no,
yeah,
sorry. No
yeah.
worries.
So let me know when can I start.
Yeah, you still have time.
Yeah. Hello.
Okay, time's up. Let's go. I'll give you a 4 minute prompt timer here.
Okay. So hi, I'm your ED doctor for today. How may I address you?
My name is Melissa, doctor.
Hi, Melissa. So what brings you here?
Oh, doctor, I don't know what went on, but I'm suddenly having this little bleeding from down below. It's so weird.
Okay. So before Melissa, before we can continue, I would just like to confirm with the examiner if my patient is hemodynamically stable.
Hemodynamic stable, proceed.
Yeah. Okay. So, Melissa, so when did this bleeding exactly start?
Well, doctor, it was just yesterday, doctor. It's just so quick. It just happened so quickly.
And how much did you bleed?
Well, it's been little very light bleed.
Okay. And what color was it, bright red or a brownish discharge?
It was just ready, doctor.
Okay. So, so are your periods regular?
Well, they used to be regular, but then recently I haven't really gotten my periods for about like some time.
How long exactly?
8 weeks, doctor. And you know something? I actually think I might be pregnant, doctor. My husband and I have been trying, and I actually went to a chemist like 2 weeks ago, and then I did a urine pregnancy test kit. It was positive, but then I was like, I don't really have any symptoms. I was like, maybe I'm not pregnant, and then I forgot about it.
Okay. Okay. Um, did you, so you didn't get a urine pregnancy test, right?
I got one from the chemist, doctor.
Okay. So do you have any symptoms like breast soreness or nausea or vomiting?
Well, I did have them like about like 6 weeks ago.
Okay. And is this your first pregnancy?
Yeah, if I'm pregnant, this is my first pregnancy.
Okay. And are you on any pills, before, you stopped getting periods?
Well, I was on oral contraceptives, doctor.
Okay. And so you told me that you have a husband, and do you practice safe sexual practices? And before you answer, I would like to tell you that everything we're gonna talk is going to be confidential, and I might ask you some personal questions too.
What was the question, doctor?
Do you guys practice safe sex?
Oh, no, he's my husband, doctor. I don't have to be safe with him.
Okay, so you don't use condoms particularly,
No,
right?
and we wanted a baby, doctor, so we don't use
Okay,
condoms.
got it, got it. And so, do you have any history of any infections or rashes before
Um,
in the genital area?
no,
Okay. Any surgeries that you've got done before?
no.
Are you up to date with your pap smear, the HPV screening?
Um, yeah, doctor. Got mine 1 year ago.
Okay. And do you have any flu-like symptoms, any fever right now? Are you
No.
experiencing any abdominal pain specifically?
I don't have any abdominal pain, but I do have like this little like tummy discomfort, you know?
Okay. And is there any nausea, vomiting currently?
No.
Are you feeling tired?
No, I'm fine, doctor.
Okay. So excuse me for a moment. I would like to ask my examiner some findings, and then I'll come back to you. Is that all right?
Mm-hmm.
So dear examiner, I want to know the general appearance of the
This is
patient.
your 4 minute prompt timer.
Okay.
Patient
Uh,
looks patient looks distressed.
okay, distress. And the vitals of the patient, BP, pulse rate, temperature.
120, 120, 80 BP, 80 minutes, 80 beats per minute and regular for pulse. Temperature normal.
Okay. And the BMI of the patient.
Normal.
And on uh, any on the breast examination, is there any engorgement, any nipple changes?
Mild engorgement found.
Okay. And on the per abdominal, on inspection, I want to check for any scars, distension, swelling
Where? On the abdomen?
on the abdomen.
Normal.
And on a per vaginal, also want to do a per vaginal examination with the consent and chaperone present.
Mm-hmm.
And want to see on inspection of the vulva, is there any redness, rashes,
No
or
redness, no rashes.
and if the on the per speculum examination of the cervix, if the os is open or
Os is
closed,
closed. Os is closed.
os is closed, and any fresh bleed seen in the vulva vagina.
No blood in vagina.
Okay. Thank you, examiner. So, I would like to go back to my patient.
Yeah.
So, hi, after thorough history and examination, I would like to do further things with you. So, you might probably be pregnant. So,
Mm-hmm.
for to confirm that, we need to do a urine pregnancy test here.
Mm-hmm.
Oh, sorry, I missed it out. I will just check with my examiner. So, an
Urine
exam,
pregnancy test positive.
yeah, positive. And blood sugar level.
Normal.
Okay. So, and urine dipstick if it is available.
Normal.
Okay. So, hi, Jane. Congrats. Your pregnancy test is come positive. So, you are pregnant. So now, further, we would like to do some more investigations. Like we'll send your bloods for full blood examination, urea, electrolyte, creatinine, and your blood sugar levels and your thyroid test and LFT, liver function test.
Mm-hmm.
And from now on, we'll be
Doctor, so why did I have the bleeding, doctor?
to address that, you could be probably having threatened abortion, is what we call. So your on examination, this is a condition where your baby, you might have gone into the state of abortion, but your baby is still safe. It's viable, and but since your os is closed and there's only minimal bleed, that you were at almost the risk of abortion, but you
Mhm.
have, now the baby is not aborted yet. And for that, we would like to admit you first.
Mhm.
And I would be calling the registrar
Mhm.
and the obstetric registrar. And I would advise you a complete bed rest for now. And
What about my baby, doctor? How are you gonna check my baby?
so for that, we'd be doing a ultrasound.
Time's up. Okay.
Yeah.
To save you from the critical error of ultrasound.
Yeah.
Okay, well
Thank
done.
you.
Good job, good job. Okay, so there's a few things. Read the task carefully. So let me just go to this slide for everyone, so it's a bit easier. So yes, the tasks are getting confusing nowadays in the AMC exam. It is the one complaint I receive from every single candidate. So it's not easy, and the eyes will miss it. So carefully ask the examiner for the findings, specific, general, and gynae. They've already told you what you need to ask. So don't need to go and ask for CVS or I mean you didn't. I'm just giving examples.
Yeah.
CVS. And again, results of any test you would need at this point in time. There are
Yes.
a few key things that are here. You need to know the blood grouping for your
Hmm.
NTD. That was a
Yeah.
little miss. Okay. And then advise the patient of the probable diagnosis. So follow the steps. Probable diagnosis first. You went to management and it felt like you were struggling to tell me that I have a miscarriage. They
Yeah.
they already know it. So just say that it just like you might be having this, but everything is fine now. Save it. So give her
Yeah.
the story, but you are fine now. We're just gonna make sure you continue to be fine. And then
Yeah.
I'm gonna do all this for you. So it will the story will flow if you follow
Mm.
the task. This is the problem, but we're gonna do this to save you and to make sure everything is okay.
Correct. I almost forgot she had vaginal bleeding. I'm just like, she thinks she's pregnant. She's not. So I'm on the focus that she's,
Yes.
yeah.
I forgot. So I had to ask you, what's wrong with me, doctor? Why am I bleeding?
Yeah,
Right?
correct.
So just take note. The task can be confusing. Okay,
Yeah.
so let's look at the PP that we had to ask. So
Hmm.
key was the cervix. Have to ask about the cervix. Now she might be pregnant. So I didn't really get the question which you were asking about the per abdomen. You asked for you didn't ask about the uterus and adnexa. So I didn't really give those ones. You only asked because it says in yellow. Right? I highlighted it.
No,
Only
in uterus, I thought like till 12 weeks, when you're pregnant, you can't palpate the uterus, right? Till 12
in,
weeks.
in your thinner patients, you still can because it will be bigger than usual. In your fatter
Oh,
patients, it's a bit difficult. So it's case by case basis.
okay.
It's
Yeah.
just that when you do your transvaginal ultrasound, you need your beta HCG to be more than 1,500 to visualize it, but that's roughly the only marker that we use. Should be able to, not every time, but can feel. No harm asking.
Got it. Yeah.
And pregnancy test, yes, had to, yes, you asked that and you came back to it. So that saved you coming back to it.
Yeah.
And just add the blood grouping inside. Okay.
Yeah.
So
Yeah.
these are key things that we need to ask everybody. So if you do the handbook more often, this will become habit to you. You will start seeing yourself becoming matching to the handbook before your exam, just the ideal that we hope to achieve. Now, these are things that we need to give advice to the patient. So yes, she needs an ultrasound, which is why I asked you what's happening to my baby, and
Yeah.
to get the diagnosis of the threatened abortion miscarriage. Now, one question that I had a little bit tricky issues was, um, you could have done a better history for the CCVOB a little bit. And has the bleeding stopped? The bleeding has actually stopped for this patient, but you didn't identify, is it still bleeding? Have you stopped? Like what's going on? So you can
Correct.
ask if it stopped, what
Yeah.
exactly is coming out. So focus on that a little bit. And usually when you ask in ops and gynae question, everybody, please remember, CCVOB, when you come to volume, it's very hard to identify how much. My little might not be the same as your little. The best way is number of pads. Ask them, how many pads have you used? Every OBGYN, you can ask this. If it's a pediatric case, wet nappies. How many wet nappies have the wet nappies decreased? So that is how you get your volume. I remember I always tell this to everyone. I had this candidate who I did OBGYN case with, and it was a bleeding case. And she asked me, how many tablespoons have you bled? And I was like, doctor, I don't use tablespoons to calculate my amount of blood. So please, the right question is number of pads. I know you're creative in the exam, you get a bit stressed and you become very creative, but pads is the best way to go. Now, hemoglobin and your indirect Coombs test, because NTD will be key as well. NTD management, please check guideline. I'll write it down to send you guys the NTD management guideline, the new ones. I'll send it to you by tonight. That will be for this case. And yes, critical errors in this case. So key issues and critical errors. For those who exam in July, just only focus key issues, critical errors. Don't bother too much about other things because these are the only things you need to clear off. Make sure you're clearing them off when you do your consults. So confirming doing a pregnancy test kit would have been key. Yes, she checked, but we always need a confirmatory in the clinic. And if your patient tells you, oh, doctor, but I already did it. I'm already pregnant. Why are you doing this test for me now? Tell her we just want a record of it. Therefore, we need to do it in the clinic. Okay, check the ultrasound. Again, you 100% won't know if this is a threatened miscarriage. Yes, it sounds like a threatened miscarriage picture, but we still need to check the viability of pregnancy, which now the next question comes in. Is she really okay? Are we sure that she's okay? Now that's the next question that we have to ponder about. So case by case basis. These are other things to remember when you are doing your cervical os. The one thing to remember when asking about your cervical os, please do mention that you will be using a speculum. So start with inspection. Swarna, I will send you your feedback separately with everything I've written, so no worries. We'll come back to it.
Sure. Thank you.
No problem. When you're doing inspection, inspect first, then put the speculum inside and always look for whether there's an active bleed going on or any clots. If you see a clot, the rule is to take a forceps and remove the clot and then continue on your inspection. So remove the clot. Now that I think might have been a bit of a critical error because when I had the same case for my exam, I told the examiner I'm going to remove the clot and his eyes opened up like a baby. And I was like, okay, I got something right in this case. I removed the clot. So I think it's important because I've seen the examiner's eyes light up when I say I'm going to remove the clot. So please, if you have similar cases, clear off and then continue your inspection. All right, that will be the end of today. Any particular questions that you guys have with these two cases? I know I was supposed to explain a little bit about physical examination, so I'll tap on that very quickly while you guys are pouring any questions that you might have. I know it's a lot to take in. We will have more sessions for handbook because I think that will really help us be as close as possible to the AMC standard, so we can definitely do that. Someone asked me about physical examination. When you have to do a running commentary with the examiner and when you're talking to the patient, the best way I always recommend is to call out. So examiner, I'm looking out for any pallor, any jaundice, any icterus. You say whatever you want to say. And then you talk. Maybe the girl's name is Jenny. Then you're like, Jenny, I want to tell you that. Can you please lift your arms for me? Can you please push against my arms? Can you resist me if you're doing any neuro examination? So make it very clear on who you are speaking to. One, because you're most likely not the first candidate. If you're an afternoon candidate, they've already seen the first 20. You are probably number 26 or 27, so they're going to be tired. A lot of your examiners are a little bit more on the older side, so hearing might be a problem. And you don't want them to miss out. So grab their attention, give your statement. Grab their attention, give your statement. And if you have a mannequin involved, it becomes a bit harder because you're talking to patient, running commentary to examiner, looking at the mannequin. Now, a lot of people are very confused with saying I am looking for versus I cannot see. If you are looking at the mannequin, you would say I cannot see. The reason is because the mannequin has been designed to give you the exact answer or exact physical examination finding that you need. Therefore, what you see or what you don't see, you exactly say what you see when you're looking at the mannequin. But now you have a patient. This patient, let's say it's a heart failure case. You're not going to expect a heart failure patient to be the real patient who's there. So, which is where you're going to tell the examiner, I am looking for. It's a very practical, very straightforward concept. I am looking for. So only if the examiner knows what you're looking for and it's a positive, the examiner will tell you yes. This is so example you're hearing. I'm looking out for any kind of S1, S2 murmurs and added sound. The examiner's like, murmur present. Then you're like, can you describe the murmur to me, examiner? So if you don't tell them what you're looking out for, they are not going to be bothered to tell you that, hey, this is the finding that's there. So remember, mannequin, you say that I cannot see or I can see because it is what it is. For a patient, every time you go, I am looking for. However, there are times where you're talking about a patient and let's say everything is normal. At this point in time, the examiner will want to save his breath. He will tell you, say what you see. So listen to what the examiner says. Be ready and flexible to adapt to what the examiner is telling you. That is something to remember a little bit when it comes to PE, mannequin versus patient versus examiner. Can you tell for beginners, when should one exactly start doing role plays? Well, we can start anytime. So anytime, start anytime. Try not to refer first. See where you stand, and then know your standard, and then see where you need improvements, and then work little by little if you're a beginner. I got a couple of things that's coming up for you guys. Some are paid, some are not paid. I will try to increase the free ones as well. All right, I will try my best. So we have a 3-day psych crash course coming up. That will be on 28, 29, and 30 July. As you know, I do have trouble sticking to hours, which means I always extend by accident. So I know I write 2 hours here, but I'm very sure it become 2 hour 30 minutes. Maybe I should start increasing the time that I have. So that will be 120. And then I have a 3-hour med search revision session. So this session is very encouraged for those who have your July end your exam, and if your exam is in August. I'll repeat this session again towards the end of August. So between September candidates, you can wait if you want to wait, because the med search revision is going to be fast. Because you're already expected to know the knowledge. It is just the whole concept of getting you to remember the differentials, use your brains a little bit. So we're going to be interactive, chat box, quizzes, and just remembering, forcing our brains to remember. So that's what we'll be doing for the med search revision. So you can text me to enroll yourself in that. So it's next week, is it? Next week, 15 July. I'm waiting for the July 1st batch to finish first, then I'm launching this one. And of course, handbook discussions, they will go on in this method. Today, we only did a few because we did an introduction. But days to come, I would like to do 4 to 5 per session, and then we have more things clearing up. And the more confident you guys get, the more better I can give you feedback directly here instead of giving you guys private feedback, so everyone can learn openly about that. The other things is, of course, trial exams and role play sessions. So I will send my booking link through the in the chat box, and then you guys can always book yourself for those sessions. Any particular questions for today? Oh, sorry, I do have a few more questions I need to explain. Sorry, guys, I missed it. In ultrasound, transvaginal. Transvaginal, usually beta HCG more than 1,500, you can see. You only do your pelvic trans-abdominal ultrasound if it's a virgin. I mean, like she hasn't had sex before, or she doesn't have any partner. You'll be confused. Stay safe. Do trans-abdominal. If she's already pregnant, she wants to identify she's pregnant, transvaginal. Oh no, so from Dr. Mona, online and face-to-face, we actually don't have much of an option. So face-to-face, because I love face-to-face, okay, therefore I pick face-to-face. But online exams are reserved for your rural GP doctors or for GP doctors who are already working. So it's a bit hard to get onto the online list. And they only have about 20 candidates per month, if I'm not wrong. And they don't even have it every month. So be a little bit careful when you're doing your online versus face-to-face. 98% of us are going face-to-face these days. So even if you have a gap, I think with good practice, good revision, you can get back on track, no problem. No worries, guys. I will send, we can actually do PV. Yes, you can do we actually can't do per vaginal. Well, you can. The only time you are concerned is during your placenta previa. 3rd trimester bleeding, placenta previa. Please do not stick your finger in there. All right, do not do per vaginal. The other time when you're not going to do a per vaginal is if you have any discharge. So you can do a speculum, because if you think about the concept carefully, a speculum exam, it doesn't go beyond your transcervical zone. You open it at the beginning of your transcervical zone, and it kind of stops here. So which means you're not pushing your discharge into the endometrial uterus layer. It's only being here, stopped here. So you can do speculum examinations in your discharge cases, but do not do what's that thing called? Do not do PV. However, a PV is warranted if the patient has abdo pain and you're concerned of PID. Then you need to elicit your cervical motion tenderness. So discharge plus abdo pain, you do per vaginal. Discharge plus no abdo pain, don't do per vaginal. That is your guidelines. I checked it last week, so I am very sure with my answer. No, don't do. Yeah, herpes don't do. All right. Thank you, guys. I will end the meeting. Anything? Oh, small questions. Virgin or vaginal? JP, there's a difference. You changed the entire question. Yes. But with discharge, JP, as I mentioned, discharge plus abdo pain, you are concerned of PID. So you want to elicit your cervical motion tenderness to diagnose your PID. Therefore, you would do PV. But if it's discharge plus no abdo pain, you don't do what's that thing called? You don't do your PB. Make sense? All right. See you guys. Good night, everybody.